So this is episode 39 from Singapore, and we're going to be doing cardiac output and its effects on volatile pharmacokinetics. So it's not based on a short answer question per se, but it is a segment of some questions which relate to sort of washout of volatiles. And what we're going to cover is how does cardiac output affect volatile pharmacokinetics? And it is an extremely conceptual idea. I think the idea of washing is a lot more simple to discuss, and the idea of washout, which I'm going to go through, is a lot more complicated. And for that reason, you can see that's why a lot of textbooks don't actually discuss it. And in fact, if you do get a question on it, I think there's a simple way to answer it, and then there's the more complex way to answer it. But I think by understanding the more complex way, it'll help you understand the idea of how cardiac output affects volatile pharmacokinetics. And I think that's why a lot of trainees find it very difficult to appreciate the concepts. Understandably, can I say. This is the literature I've used, primarily Miller's, Chapter 20, Hemmings and Egan, Chapter 3, Evers and Mays, Chapter 25. For this talk today, a lot of it is going to be based on simulations that I've done through Gasman, and it's a program that's been designed a couple of years ago, and it's freely available now on the internet, and I've put the link up on the Patreon post, and it just helps understand inhalational anesthesia uptake and distribution. Now we're going to start off with how Miller's describes the pharmacokinetics of inhalational agents. We're just going to follow through this diagram here. So we've got the vaporizer, and that gets delivered into the circuit. From the circuit, it has equilibration with the alveoli, and then from the alveoli, it equilibrates with arterial blood. And from arterial blood, you can see that it gets distributed to three compartments. So first is what's called your vessel-rich group. Second is the muscle group. And then third is the fat group. And there's actually no interdependent relationships between your vessel-rich group, muscle, and fat. Like they're all separate compartments, all connected via the arterial blood. And what happens is that each of them will redistribute back into mixed venous blood and then back to the alveoli. So that's the primary pharmacokinetic model of how inhalational anesthesia works. And I'll show you how the other texts present it and how there's a lot of similarities between them. This is the one from Hemmings and Egan. And again, I just want to pause for a second, because what is confusing about Hemmings and Egan is that they've got the percentage of volume percentage, which is mils per 100 mils. And they have it for inspired SIVO, expired SIVO, alveolar gas. The problem is that once you head over to arterial blood, this is where I can't seem to make sense of it. So arterial blood, you've gone from 2% to 1.28%. Fat goes to 0.3%, less than 0.1. Lean group is 2%. Vessel-rich group is 1.9%, and mixed venous is 0.89%. I don't know how they work out the volume percentage, and I think that's the dissolved portion of it. So there must be something to do with, you know, the partition coefficients involved. For myself, I think I would use the partial pressures that have been written here to help understand this idea here. So what I've done is, for this diagram here, I've just taken away the dissolved portion for each group, just so that it helps with my understanding of how this kinetic model works. And let's follow through again. So we've got the inspired sevoflurane from the vaporizer heading off into the lung, and that is part of alveolar gas, which, as you can see, is the same as your entitled or expired gas. Now, the other thing to see is that 15 millimeters of mercury is the same as that in arterial blood. So there's rapid equilibration between what's in your alveolar or what's in your lung and what's in arterial blood. And then after that, it gets split off. And this is really interesting. And I think it's really important to help you understand how cardiac output affects volatile pharmacokinetics, because you can see the distribution between all the groups, depending on the cardiac output. So 75% of cardiac output heads off to the vessel-rich group. 20% of cardiac output heads off to the lean or muscle group. And then 5% of cardiac output heads off to the fat. And we can ignore the vessel poor group because that's less than 1%. And that's going to be negligible in terms of impacting volatile pharmacokinetics. Now, from there, each of those three groups, so the vessel-rich group, the muscle group, and the fat group, head back into your mixed venous blood and then head back to the lung to get expired. What is really interesting about this is this idea here, is that the brain is not separate like the ones we see in the intravenous models. The brain is actually part of your vessel-rich group in this pharmacokinetic model. In other words, the concentration that's in your vessel-rich group actually determines the concentration that's in your brain. And we are going to expand on that point later on in this discussion here. Now, this is the diagram from Evers and Mays. And again, this is actually really nice to help you sort of understand. So we've got the vaporizer, which he represents as a tap, and that heads down into the circuit, or what's called the breathing system. And then through a combination of fresh gas flow and your minute ventilation, heads off to the lung, where it gets equilibrated with arterial blood. And from arterial blood, it gets distributed to three compartments. So the vessel-rich group, the muscle group, and the fat group. And we know from the previous diagram that in terms of the distribution of cardiac output, 75% heads off to the vessel-rich group, 20% heads off to muscle, and then 5% heads off to fat. Now, this is the Gassman simulation. So this pharmacokinetic model is actually what Millers and Hemmings and Egan has also referenced in terms of some of the results that they have published. And what I've done is I've just used it as the source of truth. And what we have here is that we've got the volatile agent, and consider this to be the vaporizer, and it heads into the circuit. So this is the circuit concentration. And then after that, it starts trying to equilibrate with the alveolus, which rapidly equilibrates with arterial blood. And as you can see, it then gets distributed into three compartments, gets distributed into your vessel-rich group, into your muscle, and then your fat. And remember from the previous diagram, this is where your brain exists. And then from there, all the three compartments head back into your mixed venous blood before going back to the lung. And what I've done is that I've put this diagram in to show you how I think a lot of us conceptualize drug administration. But this is for intravenous drugs. So for intravenous drug, we've got the central compartment. And then after that, we've got this idea of the rapidly equilibrating compartment. And then after that, we've got the slow equilibrating compartment. And I think that what you guys have sort of realized is that there is a difference, because often the central compartment is what we call the blood volume. And V2, a lot of us would sort of mention it as your combination of your vessel-rich group or muscle. And then your V3, we would often say fat or bone. but the idea of the central compartment doesn't really exist in the inhalational model, because instead it's replaced with the idea of lung that rapidly equilibrates with arterial blood. And I think in some ways that is probably more representative of the of this idea of the central compartment. Now, the other thing which volatile pharmacokinetics don't have is that they don't have this idea of the effect site. And then the other thing that they don't have is that they don't have K1O, because when we think about clearance, it's often clearance from the lung. Okay, so hopefully this will help you understand pharmacokinetics models. That when we think about three compartment models, I think leave it for intravenous drugs. But when you bring in the idea of, you know, vessel-rich group, muscle, and fat, think about it in terms of volatile pharmacokinetics. And yes, I put this cross here to say that keep them separate. And I think that will help you understand volatile pharmacokinetics better. Now I've got this blank
Dan,
diagram.
can I just ask a question?
Yeah, go for it, Chris.
So with the, I think, I may be wrong, but I think in one of the exam reports, they talk about, in terms of washout, you know, candidates who demonstrated a tri-exponential like washout curve. I guess my question is, if we're going to draw a washout curve and talk about it as a tri-exponential curve, are we, I may be jumping the gun, but are we then trying to relate that back to compartments in terms of why it is tri-exponential? And if we're not using that model there that has the different compartments, what sort of, I guess that how do we draw that, or how do we represent that?
Yeah.
Or do we just talk about it in prose? I don't know. Yeah.
And with the idea of you know, a tri-exponential model or bi-exponential model or even a poly-exponential model, it's that idea of different compartments. Is that right? Isn't that right, Chris?
Yeah. Yep.
Yeah.
Yep.
So when we talk about different compartments, each compartment has its own qualities about them. Would you agree?
Yep.
And so the idea is, when we think about it in terms of the volatile pharmacokinetic model, what we have to understand is that each of those compartments will have their own qualities associated with them, and they are going to be impacting how the curve is going to look like. And what you can do is you can use that idea, and instead of saying that, you know, this is due to you know, the central compartment heading off to V2 or the central compartment heading off to V3, what you would say instead is that this is the circuit or the alveol or the lung or the alveolus rapidly equilibrating with the circuit. The second phase would be the lung or the alveoli equilibrating with your vessel-rich group. And then the third phase would be the distribution to the muscle and fat, which is a lot slower in terms of its kinetics. But does that make sense?
Yeah, that makes sense. Thanks, man.
And you can use those same ideas, you know, when you think about the models for the intravenous agent, but you would describe them differently, okay, because of how they perform. So I'll just go through it with you again.
Yeah.
You know, we've got the vaporizer, and that heads into your circuit. Okay. And then with the circuit, that starts to try to equilibrate with the lung. And then with the lung, you can get distribution. And I'm writing it both ways just to help you understand. But in the initial phase, it's going to be distribution to muscle and fat. And then that is going to determine the concentration that your vessel-rich group is going to be equilibrating with the lung. And I'll explain that idea with the models, okay? But essentially, this is what it should represent, and this is what's represented in those three texts, is that we've got the idea of the circuit heading off to the lung, where it gets distributed into muscle and fat. And ultimately that is going to affect the concentration in the lung, which is what the vessel rich group is going to equilibrate with, which is where your brain is. Now, this is the first question. How does cardiac output affect volatile washing? And I think for all of us, we're going to be referring to this diagram here, and this is in Miller's chapter 20. And what we have here is that we've got two gases. So we've got desflurane and we've got isoflurane, and then we've got three different cardiac outputs. So 2.5, 5, and 10. So this would we consider low, normal, and high. And you can see that when you've got low cardiac output, your FA, FI curve, or the alveolar divided by your partial pressure that's being delivered, reaches equilibration faster. So this is the top one here, which is desflurane, and you can see that it reaches equilibration faster. And you can see that when you have high cardiac output, it takes much longer to reach equilibration. So a high cardiac output here, I'll just draw with a red line, comes down here. And you note I use the term equilibration because what we're looking at is we're looking at the partial pressure of the alveolus trying to equilibrate with the circuit. Okay, and I think that this is one of those ideas again, you know, when I was discussing with the intravenous drugs and the idea of hitting a certain threshold where onset occurs versus equilibration, which is when the effect site matches the plasma. And similar to this idea again, we've got different ideas here. So the idea is when is the threshold being reached? And then the second idea is when is equilibration between two compartments achieved? Now, I think quite simply, if you got asked the question on this, the really basic premise of your answer should be that a low cardiac output equals a faster washing, so that your alveolar partial pressure of the volatile agent reaches your inspired partial pressure a lot quicker. Now, the premise of all this is that the assumption here is that your alveolar partial pressure equals your brain. And this is really important for you to understand what this means, because it also allows you to appreciate the limitations of this assumption. And I think once you appreciate this idea, it'll help you appreciate why cardiac output and its effects on volatile pharmacokinetics is really complex. And I think that's why a lot of trainees struggle with this idea. And when I say trainees, it's not even just trainees. In fact, all anesthetists, I think, would struggle with the idea of explaining how cardiac output affects washout of volatile agents. Now, washing is a lot simpler to explain, and I'm just going to show it to you with simulations with the Gasman model. This is the setup that I've done. So I've used sevoflurane. It's a semi-closed circuit to represent what we would normally use in our anesthesia theaters. Weight of the patient is 70 kilos. The aim is to get a MAC of 1, which is an end-tidal in this model here of 2.1. The fresh gas flow, I've left it at 6 liters per minute, which is not what we do. We often use low flow anesthesia once we have achieved, but I've just done it just to exclude any sort of issues with the circuit. Minute ventilation is set at 5 liters per minute. And what I've done is I've set variations of the cardiac output. So we've got normal cardiac output at 5 liters per minute, low cardiac output at 2.5, and high cardiac output at 10. Now, this is the results here. And what we can go through is at each point, what all these different arrows mean. Now, the first arrow I want you guys to sort of focus on is that from cardiac output, which is the normal cardiac output of 5 liters per minute. And the green arrow represents when the alveolar partial pressure reaches the threshold of MAC of 1, which is the end tidal of 2.1. And you can see that the alveolar partial pressure reaches that at approximately 20 minutes. Now, the assumption here, right, is that your alveolar partial pressure is your brain's partial pressure. And this is what I want to show you, is that if you actually look at this diagram here, the red represents when the partial pressure in the vessel reach group reaches that threshold of MAC of 2.1. And you can see that the red one approaches it a little bit later. So it approaches it at about sort of about 26 minutes. And I think this will help you get that appreciation, is that, you know, when we measure MAC, one of the key things about measuring MAC is that once you've reached your alveolar partial pressure, you must allow 15 minutes for that equilibration to occur between alveolar and brain. And that is actually one of the conditions of measuring MAC. And I'll sort of show it to you on another slide. Now, the blue arrow is when equilibration between alveolus and vessel reach group occurs. And you can see how, by understanding these 3 arrows, you can now see how they differ with cardiac output. So when let's head off to low cardiac output. With low cardiac output, what you can see is that your alveolar partial pressure reaches that threshold a lot faster. And your vessel reach group partial pressure reaches it about 20 minutes. So that's also faster as well. And I think that's why that conclusion is that a low cardiac output is associated with a faster wash-in and a faster onset. But the big difference here is that when you look at the equilibration, when equilibration happens, it happens much, much later on, okay? So when I talk about equilibration, it's the equilibration between alveolus and the vessel reach group, where the brain is, or essentially it's the equilibration between your alveolus and your brain's partial pressure. And understanding this will help you understand what you see clinically with a lot of patients with low cardiac outputs versus high cardiac outputs. Now, with patients with high cardiac outputs, what you immediately see is that the alveolus doesn't actually reach that threshold until much, much later on, so over an hour. And I think that with the simulation that I've done, I have fixed the inspired concentration at 2.65% at a fresh gas flow of 6 liters per minute. Obviously, if you have a patient with a high cardiac output, what you are going to be doing is that you are going to be running much higher fraction inspired concentrations of volatile agent. But for this simulation, I haven't done so, which is why it's taken much, much longer for the alveolus to reach that threshold. And because of that, the vessel reach group is also taking much, much longer to reach that threshold. But what is really interesting is when it reaches equilibration. It reaches equilibration much faster. And I think that this actually shows you the impact of cardiac output. So cardiac output affects how high or low the threshold is, or how high or low the alveolar partial pressure can actually reach. And then the other thing that cardiac output affects is when equilibration happens. Now I'm going to explain in the next couple of diagrams why these differences occur. Now this is the, these are the compartments of each of these simulations. And one of the things that I want you to note is this is at the end of 1 hour. And at the end of 1 hour, what you'll see is that your alveolar and arterial and vessel ridge group have pretty much equalized, okay? This is really important to understand, is that at the end of an hour, or in fact, you know, even, and you can see even with the previous diagrams, within sort of 30 to 40 minutes, your partial pressure in your alveolus should have equilibrated with the partial pressure in your vessel ridge group, where your brain is. The other thing is that as you start increasing your cardiac output, what do you notice? You notice that the concentration in the vessel ridge group starts decreasing. So do you see that? So 2.37, 2.2, 1.99. And that is because the partial pressure in your alveolus starts decreasing. And so in other words, the partial pressure in your lung is inversely proportional to your cardiac output. And why is that? The reason for that is because of this, is that if you look at muscle, what happens with muscle? As you increase your cardiac output, the amount that gets distributed into your muscle starts increasing. And so what you can see is that the concentration in muscle is directly proportional to your cardiac output. And because of muscle drawing away volatile away from the lung, that is what decreases the concentration in the lung, which then decreases the concentration in your vessel ridge group, which is why patients with a high cardiac output tend to have a slower onset versus someone with a low cardiac output will tend to have a faster onset because they reach that threshold faster, because a lot of that a lot of the drug, also a lot of the volatiles will be contained within the lung, and also because the vessel ridge group, which contains 75% of the cardiac output, is the one that's going to be equilibrating with the lung. Now, I'm just going to go through this again because I think this is really, really important to show you and help you understand. So what I've done is I've just used this model here, which I think will be a lot clearer for you. So we've got the vaporizer that I've set at 2.65%, fresh gas flow at 6 liters per minute. And this is just at the start. So the circuit's got 0%, the lungs 0%, vessel ridge group 0%, muscle 0, fat 0. And what I have here is I've got the time constants. So I've got the time constants from lung to muscle, and that's just the formula. It's your solubility multiplied by the volume size divided by your cardiac output. Okay, so these are the time constants for each one. And remember that when we talk about it in terms of the intravenous model, we're talking about the rate constants. So here I'm talking about time constants. If you want to get the rate constants or the elimination rate constants, remember that the elimination rate constant is essentially the inverse of the time constant. Okay. But for this talk here, I'm just going to focus on the time constants because I think that will help you understand and appreciate the key concepts of cardiac output. So what happens at 5 minutes? Okay, so we've got the vaporizer at 2.65%, and then the circuit's at 2.1, and then your lung is at 1.56. And you can see that there's distribution to the muscle and distribution to the fat, although you can see that the fat's kinetically slow, so it's still at 0%. And then after that, you've got the vessel ridge group at 1.01%. Now, this is really interesting. So what I've done is I've superimposed what happens with patients with low cardiac output. And with patients with low cardiac output, what I think should be immediately obvious is that the circuit concentration is higher and that the lung concentration is higher. And the reason for that is because there's less redistribution into primarily muscle, okay? And you can see that normal muscle was 0.04%, and it's half that at 0.02. The other thing that I think you'll also note is that the vessel-rich group is actually lower initially. And so, in other words, there's actually less distribution to your vessel-rich group and also your brain. So initially, in the first 5 minutes, despite having a higher concentration, concentration of volatile in the lung, your vessel-rich group is actually lagging behind. And the reason why it lags behind is because of this idea of that time constant, where a reduction in your cardiac output is going to be increasing the time constant, or the time it takes for your vessel-rich group to equilibrate with your lung. And I hope this diagram here explains to you what low cardiac output does. So low cardiac output allows you to achieve a much higher concentration in the lung, but the flip side to it is that equilibration between the lung and vessel-rich group takes a little bit longer, okay? Now, this is what happens with someone with high cardiac output. And what should be obvious here is that your circuit percentage is down, your lung percentage is down, and the amount of distribution that occurs primarily to muscle is actually increased. And that helps explain why that concentration is down. The other thing that you'll sort of see is that your vessel-rich group is a lot higher. And what is happening here is because you've got a much high cardiac output, the equilibration between lung and vessel-rich group is happening a lot quicker. But the downside to this is that because you're having a lot more distribution from the increase in cardiac output, you are only achieving a much lower concentration. And therefore, even though you're reaching equilibration faster, it's equilibrating at a much lower concentration. And therefore, that explains why onset in a patient with a high cardiac output is slower, unless you correct it by increasing your fraction inspired of volatile agent. Now, this is what happens at 30 minutes. So at 30 minutes, you've got your circuit at 2.42. This is someone with a normal cardiac output, 2.42, 2.14. And you can see that within 30 minutes, you've got equilibration between the lung and vessel-rich group. And I think this is really important for you to know, is that the vessel-rich group, because of its high cardiac output, reaches equilibration fairly rapidly, okay, within 30 minutes. And you can see the distributions between muscle and fat is just kinetically slow again. This is someone with a low cardiac output. So with a low cardiac output, you can see that the concentrations are much higher, okay? The other interesting thing is that even though lung and vessel-rich group haven't equilibrated yet, they're pretty close. They're actually very, very close, okay? And you can almost assume that, that within 30 minutes, even a patient with low cardiac output, the equilibration between lung and vessel-rich group has occurred. And this feeds back to the idea of why a lot of us will use alveolar partial pressure as a surrogate measure of your brain's partial pressure, because of this idea that even with someone with a low cardiac output, you can reach that equilibration within 30 to 40 minutes, okay? Now, I think what is interesting to note is that obviously your distribution to muscle decreases, and that is why the concentration in the lung is a lot higher than someone with high cardiac output. So you look at someone with high cardiac output, all these values are lower. And the reason why they're lower is that you've got much higher concentrations in the muscle. And the problem of having a much lower concentration is that that's reflected in your vessel reach group or your brain. But you can see that this bit here has already reached equilibration already. And finally, this is the one at 60 minutes. Again, this is your normal patient with 5 liters per minute. You can see that it finally ends up at 2.2%. With someone with a slow cardiac output or 50% reduction, this is at 2.37%, so a lot higher. And again, the explanation for that is because distribution to your muscle is reduced. So a lot of it is within that is within the lung and the vessel rich group. And then someone with a high cardiac output is much lower, okay, 2%, all right? And pretty much it has achieved equilibration already. And as you can see, the reason for that is that muscle is containing a lot more of that volatile agent. So this is the summary of the effects of cardiac output on washing. The first key concept I want you to understand is that when we talk about washing, it's often defined by the concentration in the lung or the alveolar partial pressure. And I think that is really, really important for you guys to understand. However, clinically, it's the partial pressure in the vessel rich group or the partial pressure in the brain which determines onset. So those two ideas are different, but we use them synonymously. And so the question is, why do we use the concentration in the lung or the alveolar partial pressure or the end-tidal partial pressure of volatile agent instead of the concentration in the vessel rich group? Well, similar to the effect side, it's very difficult to measure the concentration in the vessel rich group. And so the assumption here is that the concentration in the lung has equilibrated with the concentration in the arterial blood, which approximates the concentration in the vessel rich group or your brain. And the idea is that they rapidly equilibrate. And I think you've seen those words being used before. And I want you to understand the context of that, because that's really important. When we talk about rapid equilibration here, it tends to occur within 30 minutes. And that is that idea of when you can safely assume that the partial pressure you see on your anesthetic machine, so the end-tidal partial pressure of your volatile agent, is going to be representative of the brain's partial pressure. But if it's early in the piece, so in the first 5-10 minutes, it's not going to be completely representative because it's still moving along in terms of going from lung. It's still being transferred from lung to your vessel rich group. So that's a really important idea for you guys to understand. Now, the second key concept, which I've sort of touched on, is that idea of equilibration. So kinetics is such that rapid equilibration, and I put that in inverted commas because that is going to rear its ugly head during the washout phase. But let's just run with this, is that rapid equilibration with the lung and vessel rich group occurs sort of within 30 minutes, as long as cardiac output is within sort of normal ranges. And what you find is that the equilibration time between your lung and vessel rich group is inversely proportional to your cardiac output. And what I mean by that is that if you have a low cardiac output, the equilibration time is a lot longer. And if you have a high cardiac output, the equilibration time is a lot faster. And this goes back to the definition of what MAC is. MAC is done at steady state. Steady state being the key. And at steady state, this assumes a constant alveolar concentration for 15 minutes. So in other words, you've reached that point where your end-tidal is no longer changing. And then that is not the point you measure MAC. You still need to wait another 15 minutes And under this assumption, this allows for equilibration between the gases in the alveoli, the blood, and the brain. This is such an important idea because often, at the start of an anesthetic, when you see an end tidal of 2, that doesn't mean that that represents what is happening in the brain. Because remember what I said before, equilibration hasn't occurred yet. Okay, equilibration takes around sort of 20 to 30 minutes in someone with a normal cardiac output, and obviously with someone with variations in terms of their cardiac output, that is going to change. So someone with a low cardiac output is going to take much longer to equilibrate. Someone with a high cardiac output is going to be a lot faster to equilibrate. And the idea of MAC is that it's done at steady state. So we're assuming a constant alveolar concentration for 15 minutes under the assumption that this allows for equilibration between the gases in the alveoli, the blood, and the brain. Now, why have I said as long as cardiac output is normal? This is the answer, and it goes back to the idea of the time constant. So the time constant is the solubility in that compartment multiplied by the volume divided by the cardiac output. And as your cardiac output reduces, so as it approaches 0, your time constant approaches infinity. In other words, if you had an extremely low cardiac output, so hypothetically, 1% of what's normal, you are never going to reach equilibration between your lung and vessel-rich group. In other words, even though your alveolar pressure in your lung may be reading 2% of sevoflurane, that is not going to be representative of what's happening in the brain. Okay, and that's a really, really important concept I want you guys to take home. Now, the third key concept for washing is the idea of what happens with distribution. So kinetics is such that distribution is proportional to your cardiac output. And distribution to your muscle, it's primarily muscle, so fat is kinetically slow. And for most cases, you can ignore it. But for most cases, it's going to be muscle. And it's a distribution to muscle which determines onset. And what I mean by that is that it determines the threshold of how long it takes to reach that concentration. Because when you've got increased distribution to muscle, it reduces the concentration in the lung, and vice versa. When you've got reduced distribution to muscle, it increases the concentration in the lung. And because the lung can equilibrate with the vessel-rich group fairly rapidly within 30 minutes, ultimately that is what's going to be reflected in terms of how quickly onset occurs. Now, the other thing with distribution is that when we talk about it to the vessel-rich group, that is going to be determining equilibration. So in other words, a high distribution or high cardiac output, which means that equilibration is going to occur a lot quicker. A slow distribution to the vessel-rich group or slow cardiac output means that equilibration is going to take a lot longer. And let me just go through the key scenarios that you're going to be faced with. So someone with a low cardiac output, they're going to have a reduced distribution to muscle, primarily muscle and also fat as well. What that means is that they are going to be increasing the concentration in the lung compared to the circuit, and that's often seen as your FA versus FI. And that is what leads to a faster washing. Now, the other thing that you need to know is that there's reduced distribution to your vessel-rich group, which means that there is slower equilibration with the lung. And when I mean slower, it doesn't mean that it's going to be hours, okay? It's slower in terms of, instead of it being 20 to 30 minutes, it's going to be 30 to 40 minutes, okay? And the clinical relevance to this is that your assumption that your alveolar pressure equals your brain actually takes longer. And I think we see that, we see that in our patients with low cardiac output states. So patients, let's say with who are elderly, and you do an inhalational induction on them, And then we go back to our you know, these concepts here, and we know that these patients have a low cardiac output. They're probably a little bit more sensitive, and therefore their washing should be quicker. And so when you do an inhalational induction on them, what you'll find is that your alveolar partial pressure reaches your inspired partial pressures very quickly, but yet they're not asleep yet, because the assumption that the alveolar partial pressure is your brain's partial pressure has not been achieved yet. So yes, it occurs. You know, the onset of anesthesia occurs, you know, can occur quicker in someone with low cardiac output states, but it's not when you think it occurs. In other words, when you see it on the screen in terms of, you know, that alveolar partial pressure of 2, it doesn't mean that their brain is 2. Their brain still needs a lot longer for it to reach that that level. And I hope that makes sense to you. And the same thing with sort of high cardiac output states. So with high cardiac output states, you get increased distribution to muscle, and that reduces the concentration in the lung. In other words, it reduces your FA-FI curve, and that leads to a slower washing. And then the other key thing is that there's increasing distribution to your vessel rich group, which means that there's faster equilibration. And the clinical relevance to that is that patients with, you know, a high cardiac output state, you can say within sort of 10 minutes that the alveolar partial pressure is pretty much what's happening in the brain. And, you know, for patients with a lot, you know, with high cardiac output states, what you notice that when you do an inhalational induction on them, their alveolar partial pressure actually takes a lot longer to reach the inspired partial pressure because of all that distribution that's occurring. But you can say with confidence that what you're seeing on the screen is probably what's being reflected in the brain.